Well, we're at 1 o'clock, 71 in California today, says Cindy Ross. Thank you, Cindy. So we'll get started here. It's 1 p.m. I'm sure people are wrapping up their basks and their whisks and putting their reports down to come and join us today. So we'll get started here. Hello, everybody. My name is Rich Brancaccio. I'm the founder and CEO here at Revive Technologies. I founded Revive quite a while ago, about 8 years ago, to help level the playing field for kids with focus and attention challenges through wearable technology. I'm joined today, in case you didn't know, by Dr. Cecil Reynolds. For those of you who don't know Dr. Reynolds, which is an N of exactly 0, I'll give you just a very brief intro to Dr. Reynolds. Dr. Reynolds is an emeritus professor of educational psychology, professor of neuroscience, and a distinguished research scholar at Texas A&M. He's the author of over 300 scholarly publications and the author or editor of over 45 books. He's also the creator of more than 40 widely used psychological tests, including the BASC, which we all know and love, which is the most frequently administered test of its type in the English-speaking world, which is a fun fact. He's also ranked 7th most influential person in the history of clinical neuropsychology, which is another awesome fact. I'm a huge fan of Dr. Reynolds, and I have been ever since I was a school psychologist. So for about 15 years, I've been a huge fan of Cecil, and I'm just so excited to have him with us today. So Dr. Reynolds, welcome.
Thank you. I appreciate you having me today. It's nice to have folks show up. As I tell people, I'm always astonished when people show up to hear me talk about what I do, because as my wife often reminds me, it's mostly just interesting to me.
I suffer the same challenge. I think most of us who are in the psychology field, school psychology field, it's not often shared our excitement on the home front. When we get a new assessment or some new research comes out, it's usually shared just by us. So we're in good company today. We have, I think, probably primarily or all school psychologists here. Again, I'm a former school psychologist. I worked here in the Wake County school system for almost 10 years. And I just like to throw out kind of what we do here real quick. We do these webinars. We've been doing these for quite a while, particularly during COVID. We don't do these as a billboard for the company. We truly use this as a platform to provide education and support to parents and school psychologists, other clinicians. So we used to not mention our products at all, because again, we're not here to sell stuff. We're here to further the science of focus forwards. But we always get bombarded with questions during Q&A about what do we do? How does it work? So we do mention from time to time, how does the science work, or how does the technology operate? And just in the spirit of full disclosure, I'll share that we do work with Dr. Reynolds. He works with us on our scientific and medical advisory board, and he does speaking engagements with us from time to time. So I want to get that out of the way. And I have a series of questions I wanted to pose to Dr. Reynolds, because I thought everyone on the call would really enjoy hearing his perspective on it. And I also want to make sure that we leave some time for you guys, for the school psychologists, to actually ask Dr. Reynolds some questions yourself. I was very excited when I got to talk to you about 15 years ago. Dr. Reynolds had a question about the RIAS. And when you picked up the phone, I said, "Oh my God, Cecil Reynolds just answered the telephone." And my wife said, "Who?" And I said, "Forget it. You won't understand. He's incredible." So without further ado, let's jump into some questions. And then again, we'll leave time at the end for some questions from our school psychs. My first question, Dr. Reynolds, for you is, as a test author, do you have any insight to share about evaluating kids specifically with ADHD, meaning any tips, tricks, best practices, anything that you find helps the assessment process go more smoothly?
Well, I guess the number one thing is to put on your patient's hat. And remember why you're assessing these kids, and you know a lot about what they're like generally, but also keeping in mind that simply because the child has ADHD or has been referred for suspicions of ADHD, it absolutely does not mean they're going to behave the same way as other children who have that diagnosis or who are referred for that diagnosis. So be prepared for surprises. There will be some. Be prepared for the distractions that are going to occur. more so than with typical referrals, although with school psychologists, we know we have to be ready for that all the time. Especially when the band starts practicing the trumpet solo in the room next door during digit span, which there's some rule about that. That's when they do that. I know. So just be well prepared to adapt, as they say in the military, right? Adapt, improvise, and survive. And so wear your patience hat and remain calm at all times.
Do you have any thoughts about test administration, breaking it down into multiple sessions versus trying to get through a whole session? You know, we could use the RIAS perhaps, for example, or other measures.
Well, you know, I don't want to pimp product today, but sometimes I can't resist. I mean, one of the reasons we developed the RIAS too is that it's kid friendly. And we get particularly good feedback on its use with ADHD kids as well as kids with autism because it goes very quickly and it moves from subtest to subtest rapidly, and kids kind of enjoy it. So we like to use things that are briefer with that. If you use things where you have very long extended testing times with individual subtests or within a battery of tests, it's more problematic with these kids. As to whether you need to break it up into multiple sessions or you can do, say, all of your achievement testing in the morning and other things in the afternoon or a different day or whatever. You know, I really don't like to develop rules around the diagnostic picture that they're coming in with, because I believe all of these things have to be decided one child at a time. My preference when I'm evaluating kids is to do as much as I can do in the shortest amount of time possible, because then I have everything. I don't have to stretch it over days, weeks, whatever, and account for changes in mood, changes in things that have happened during that time. I feel like I get a more valid snapshot, if you will, but also knowing that sometimes you just can't do that, that you do have to break it up over a series of days or even do some of the testing one week and some the next week. But the longer it takes me to complete my assessment and evaluation, the more skittish I get about the information I had at the beginning and how it relates to what I have at the end. And I also feel compelled to do more performance validity testing under those circumstances. So I add in more performance validity testing the more time the evaluation takes. And certainly if, you know, when I get to a second day, I do the performance validity testing completely again. So it's, you know, each session. So that's kind of the way I approach it. And again, it's, for me, you'll hear that a lot of my answers are one kid at a time. You know, one of the things that I see periodically on listservs and on some of the school psych and other professional Facebook pages. For example, people say, well, I don't know whether you know, we should classify ADHD. If a kid needs to be in special education, they have a diagnosis of ADHD. Should we qualify all ADHD kids as emotionally disturbed, or should we qualify them as other health impaired? And people tend not to like my answer to that. And my answer to that is, not only is there no rule, there shouldn't be. Some children with ADHD are best characterized as other health impaired. Some will clearly meet the criteria for other health impaired. I'm sorry, for emotionally disturbed. And then there are some who best qualify for services under SLD. So it's one child at a time. And a diagnosis like ADHD shouldn't be the true determining factor as to which is the best fit for that child. We need to address that one child at a time.
I love your rationale, Dr. Reynolds. One of the things I really enjoyed when I was a school psychologist was when we could take the time, and when it was necessary for a particular child to take the time within reason, you know. So as you said, it wasn't so drawn out. It was questionable. But if we could take the time to come back and bring back to parents and bring back to teachers and say, look, under the optimal conditions I was most able to provide in my office, you know, for this child, look at what this child could do cognitively or educationally. And then obviously I would call that out in the report to outline, you know, this may not be typical the way that I could break it down compared to a classroom, but people would really be interested to say, wow, I didn't know that this child had that capability or those skills, because in the real world, we don't have that luxury, if you will, of being able to carve out these large chunks of individualized time. So one child at a time.
I know as school psychologists, I would bet that everyone or almost everyone who is listening to this has had the experience of evaluating a child who a teacher referred for poor performance on their classroom test, poor performance on the standardized tests that they give at the end of the year, beginning of whenever they give them in their district. And we sit down with them and we do what we're trained to do. We develop good rapport with that child. We put that child at ease. We do achievement testing with them and they do just fine. And we realize it's not that they don't know the material and that they can't respond to the testing. It's the way it happens in the classroom. And so we have to find a way to make accommodations for that, or also find ways to remediate that issue and habilitate them to the point where they can show the same thing in the classroom that they show us in our more artificial setting. But it's important to find out that they can do it and they do know it. And that changes the intervention picture dramatically.
That's great. I always felt like it was a win when I would see a look of surprise from a parent or a teacher because the child did better than they anticipated that they would come out in a psychoeducational battery.
And so sometimes it's more surprising to parents than others. If I can tell a quick story, and I know I probably shouldn't do a lot of storytelling, but I can't resist this one.
Please.
I had a call from some first-time parents. This was some years ago. And mom had decided to leave her job and be a stay-at-home mom when they started having children. And it was their first, they were a young couple. It was their first child. And so that's what she was doing. And she had called and made an appointment with me to see her child. She was sure there was something wrong with him. And she was very suspicious that it was ADHD. I talked with her on the phone about what she was seeing and what was going on. I really didn't feel like they needed an evaluation at that point, and kind of tried to steer her that way and said, you know, well, it doesn't sound that serious to me. But she just insisted. She was really anxious and almost in a frenzy that she had to find out. So they came in and I was able to get everything done in one day. And my practice at the time was that when I would do that with a child, when I was able to get everything done, I like to meet with the parents at the end of the day and give them just kind of a brief summary of my impression at that point before I wrote a report and sent it to them. And so these parents came in and mom was visibly anxious. She was just, you could tell, she was really anxious to find out and upset, wanting to know. And so she sits down in a chair and she says, okay, you've got to tell us what's wrong with my little boy. And I said, well, his diagnosis is 5. And she just said, 5? What's that? I said, well, he's a really, really smart, curious 5-year-old. And this is exactly what really smart, curious 5-year-olds are like. And she immediately turned to her husband and pointed her finger at him and said, we're not having another one.
I picture her start Googling, what does 5, what is the diagnosis 5? What are the comorbid conditions?
Yeah.
That's hysterical. Well, I've got another, speaking of that, so great segue. This should be a pretty quick question, but I think it's always interesting to check in on this kind of litmus test once in a while. ADHD obviously is always, regarded historically as overdiagnosed, overprescribed. Is this still the case? What are you seeing in terms of neurobiology to support or continue this notion, or that you've seen it stop or decrease?
Well, I absolutely agree that ADHD is overdiagnosed, and too many kids are put on stimulant medication as a result of misdiagnosis. I am also absolutely convinced from my reading of the history of ADHD, which goes back to the 1800s. You can find one of the first reports of ADHD in a poem written by a German physician, and the title of the poem is Fidgety Phil. And you can Google that and find it, and you can find the story of Fidgety Phil. And if you read German, you can find it in the original. You can also find translations of it. But it's a wonderful description of a young man with ADHD who was the child of friends of this physician in Europe, in Germany. And it's a description of what it was like when he went to their house for dinner the night before. And their son, who he nicknamed Fidgety Phil, was having dinner with the adults. So from that history onward, and watching how it developed, and the pediatricians who began publishing articles about it in the early 1900s in peer-reviewed medical journals, and what we saw into the 1950s, and what we see now, particularly with very good behavioral neuroimaging research. I am absolutely convinced ADHD is real. It's a neurobiological disorder. So it is real. It's out there. We know what to do with it. We know how to treat it effectively. We know how to diagnose it accurately. But it is overdiagnosed. And it is typically overdiagnosed. And the American Academy of Pediatrics has recognized this as well, and they've made a statement about it to pediatricians in the United States. It is overdiagnosed because too many times there is no comprehensive evaluation. Pediatricians write prescriptions for more stimulant medication for children than any other medical specialty. And too often they do that on the basis of a parent coming in and complaining about their child's behavior. And they often complain about what are typically ODD behaviors, maybe some impulsive behavior, not following the parent's directions, things like that. Or they say the teacher's complaining about them at school. And the physicians don't do any follow-up on that. They want to make their patients happy, so they'll come back to see them. And it sounds like ADHD, and they may ask them a few questions about it, and they make the diagnosis and write the prescription because it's one of the more frequent diagnoses. But that gets kids overdiagnosed who have one of the mimic disorders. And you can actually find close to 50 things that can make a child look like they have ADHD when in fact they have something else.
That was my next question about differential diagnosis. And what do you usually see?
Well, the most prominent mimics are anxiety disorders and depression. Depression, especially in young boys, if you read the DSM, and the new edition actually elaborates on this more than any earlier edition of the DSM. The DSM-5 specifically talks about the fact that depression in boys will display as hyperirritability, agitation, distractibility, all those things that we frequently associate with ADHD. Yet it's not ADHD, it's depression. And so the only way to tease that out and get it right is to do a comprehensive evaluation. And when we do that, we get it right. We also pick up the comorbidities. It's not uncommon for a child with ADHD to have obsessive compulsive symptoms, and even to the point of warranting a secondary diagnosis of OCD. It's estimated that close to 30% of the ADHD population develops a diagnosable OCD. We also do see depression being highly comorbid, so kids can have both. And unfortunately, if they only get the ADHD diagnosis and we don't evaluate them comprehensively, we miss out on treating the other issues. And sometimes we find if we treat the other issues, the ADHD improves as well. So if we want to get to the right intervention, we've got to get to the right diagnosis. You know, one size does not fit all.
It's really powerful. It's a really powerful statement, I think, for everyone here to reflect upon, because especially when you're in a busy, high-referring school or school system, there's this swift-moving rapids that you're traveling through. And it's very easy when you are working with so many children who do have ADHD and who they do truly meet criteria to get in or to fall into that mindset of, I have another ADHD child, I'm doing another evaluation, whether you're a school psychologist, you know, doing a psychoeducational or a physician. But is what you called out, I think, is critical, because slowing down, even though it becomes so rote when you do so many evaluations that are similar, slowing down enough, because this could be dangerous for students, for patients, when you miss depression and you're throwing ADHD drugs at it and you're not actually treating the real issue. So that's really
well,
powerful.
and there are some mimics. For example, children, uh, again, who have PTSD will look often, particularly those who are prepubescent. Prepubescent children with PTSD, frequently their surface behavior can mimic ADHD. And one of the great dangers is that they'll get misdiagnosed as ADHD when they should have been diagnosed with PTSD, and they'll be given stimulant medication. And the big issue there is that when you give stimulants to a person with PTSD, it makes their PTSD not only worse, it makes it more resistant to treatment in the future, because it adds to the neurobiological problem that's reflected in PTSD and makes it worse internally for the individual. So we're making them more difficult to treat once the diagnosis does get figured out.
That's really powerful. I wasn't personally aware of that connection. So that was really interesting for me, and I hope for much of the audience to hear. So my walk away for our audience is dig deep. You know, dig deep. Don't be, it's not a waste of your time. You could catch some very valuable information that could potentially improve the outcomes for a child, because you're able to carve out a little bit more time that maybe your principal or somebody would like, but it seems it's certainly a worthwhile effort to dig deep. You actually answered my next question, Dr. Reynolds. I was going to ask about, and if we have time later, I'll drill more into it. I was going to ask about immaturity, particularly when you're working with, you know, kindergarten, first grade students, looking at ADHD versus just immaturity, as you said, with the diagnosis of 5. But I guess moving along the same plane, looking at traditional punishment paradigms, can you talk a little bit about, I guess, behavioral intervention, high level for school, and, you know, for the parents in the crowd or for those working with parents, talk about traditional punishment paradigms, negative reinforcement, things like that with ADHD.
Sure. And I do hope we can come back to the immaturity issue, because it's a big issue, and there's been a lot of change in thinking about that over the last 10 years. But with regard to punishment paradigms in particular, one of the things that we know that has been demonstrated repeatedly is that punishment paradigms are not a great way to discipline any child. They're not as effective as other paradigms, but certainly there are times when punishment is appropriate. But with ADHD children, we know that they are extremely resistant to responding to punishment paradigms. And punishment paradigms are only effective with ADHD children generally. Now, always there are exceptions. You know, I will not use the word always or never, right, if I can avoid it. But because there are cases where I'll be wrong. But in general, children with ADHD only respond to punishment paradigms in the presence of the punisher and when they are fearful that the punishment is about to be administered. And they don't learn from it. They don't develop lasting change from that. It's only the immediacy of it. And then it's over and they move on and they don't generalize. And generalizability of punishment is not terrific for kids without ADHD, but for kids with ADHD, it's almost non-existent. And that's related to the neurobiology of ADHD. The pleasure and pain centers, if you will, the emotionally within the brain, and those reward circuits don't operate quite the same way. They don't have the same metabolic rates in children with ADHD as they do in children without it in most cases. So it really impacts how they respond. And they do respond much better to positive reinforcement paradigms, clearly. And they are very resistant to punishment paradigms. And at the same time, they are so frustrating to deal with that it's so easy to shift into being punitive because we get frustrated and we don't know what to do. So we lapse into a very rigid punishment paradigm at times, and that doesn't work. You know, I've talked about sometimes when ADHD kids get upset and we try to invoke punishment to settle them down, or threats or whatever. And I tell people, don't push them down, coach them down, because they are extremely resistant to the push of punishment. And they respond much better, but it takes longer to coach them down. Listen, work with them to discover what they're accomplishing or what they think they're doing with these behaviors, or whatever has upset them, and how they're reacting to it, to understand that and reflect that to them and be sure they understand it, and use that interaction to coach them down. Because if you push them down, you're going to push back.
I'm visualizing as you're saying this, Dr. Reynolds, the technique that I think a lot of us probably incorporate along what you just said, where we will typically kind of come down to eye level to try to build some rapport, to start that coaching down process, which is time intensive for sure. And we often have the luxury as school psychologists, where the classroom teachers, it's very hard to stop what they're doing with 20 some other kids in the room. But we can leverage, you know, our flexibility to do, as you said, and to coach them down. And something I used to love to do was to, you know, try to provide a cognitive distraction to kind of just tilt for a second to get them off of whatever they were harping on or upset about, to get that teachable moment going. So I love what you've said. It's very
and
powerful.
they're distractible enough, you can distract them.
Exactly. It works
you
well.
Use what they bring to the table, right?
It's a win-win. I want to circle back on your previous comment about immaturity, because that was something for me, as you said, with the story about the diagnosis of 5, I think is challenging, because what I remember as a school psychologist was, you don't want to be dismissive for parents where there really is a concern, right? You've got a 5-year-old and they truly do encounter significant difficulty as a root causes ADHD perhaps. So you don't want to be, no, everything's fine, you're fine, you're helicopter parenting, the kid's 5, but then you also don't want to, as you said, be part of the problem. So what are your thoughts on how to be helpful with that? And
well, the issue of it just being immaturity is the key reason that we use age norms in these assessments. It corrects for age. So we look at their behavior relative to the typical behavior of other children the same age. And sometimes we have to explain that in lay terms to parents. They don't really understand how psychometrics works. They don't understand age-based scaling. All of that is like a foreign language to them. So we have to reassure them that we're comparing their child to other children the same age. And for the first time, the DSM has changed their position on the diagnosis of ADHD. It was until DSM-5 that the diagnosis was based on their behavior solely relative to age. Now it's based not on just chronological age, but developmental level. So, for example, if you have, say, a 7 or an 8 year old who has an intellectual disability, it was very common for them to get a diagnosis of ADHD as a comorbid disorder with that. That should be less so now because they may be exhibiting the attention span and the behavioral control and things that are perfectly normal for a 5.5 or 6 year old. Yet they're an 8 or a 9 year old who has intellectual disability. So developmentally, they're behaving very consistent with their overall level of development. So we now need to take that into account, the overall picture of immaturity, and relate that to their age and their developmental level. So we had been arguing for that for almost 30 years. And the American Psychiatric Association finally came around in DSM-5 and says now that the behavior must be inappropriate relative to their developmental level. And that encompasses more than just chronological age. So that's an important shift in the actual diagnostic enterprise, if you will, around ADHD, and is important for us to consider. And as you were saying, we still need to address it when parents have these concerns. And we have to do that by doing it in parent-friendly language. And it's so much easier for us to lapse into our jargon, or do like some physicians do and say, well, don't worry about that. We just take all that into account. That would work with me if I'm a parent. I want an explanation. And so we don't want to blow them off and take that authoritative stance either and say, well, just trust me, I did my job right. We should give them explanations. It's their children. What's more valuable and more precious to them, and what are they more concerned about than their children? So we want to give them good explanations in parent-friendly language so they understand how we're getting to where we're getting. And if our conclusion is, hey, your kid's doing great, we need to explain that too. Sometimes I think we feel like when we tell parents that their kid's just doing great and there's nothing here to worry about, that should just be the best news in the whole world. But it's not if they don't understand it and they don't know how we got there. Because somebody had significant concerns, or we wouldn't have spent this time and effort in doing this evaluation.
That's sage advice. I think it's very important to keep that in mind. Shifting gears a little bit towards the science, we talked about some of the punishment. We talked about differential diagnosis, if you will, and immaturity. In terms of the science, moving forward, there's a lot of new science that's coming out for ADHD, which is terrific. I think it's a paradigm shift in terms of the ADHD community in the last few years, and even in really the last 12 months, we've seen a lot of new things that have come out. Can you talk a little bit about some of the technology? One question that we get a lot is, how does something like a technology like what a Revive does, or a Watchminder or something like that, where we're using a vibration to alter behavior to improve focus? Can you talk a little bit about the neurobiology of what takes place?
Well, from two standpoints, really, I want to talk about that. One is that a device like Revive takes the place of having a person there doing what we used to teach people to do all the time. we used to try to train kids to self-monitor and give themselves the reminders that now technology can give them. We still want to teach self-monitoring, but that is so person intensive without something like the Revive technology. And what it's done is put into technology what we would like to have done all along if we had the resources to have a person with them all day, every day, until they learned how to do this for themselves. And Revive helps them learn to self-monitor, but it also is doing the monitoring, and that's how it does it. That's how I think it works. So it reconnects with their brain, if you will, when it reminds them, and it allows them to develop that self-monitoring paradigm that we know is so critical for more mature behavioral control, and allows them to redirect their attention and allows them to discover what it feels like when they're off task and know that they need to come back. You know, there's probably not a better word for it than just what it feels like in our brain. You know what it feels like when you learn a new skill, a new motor skill, for example. You actually can sense that in some way. It's like, okay, what does it feel like when you swing the golf club perfectly in that nice plane? Like some of those guys on TV do all the time.
A
You
feeling
get
of flow.
feeling with that, and you develop you develop a neural connection with that, and you can do that over and over and over. And the more you do it, the more that neural track that was successful for you is reinforced in the brain. And self-monitoring and understanding what it's like to bring your attention back to focus, understanding what that feels like in your brain and reinforcing that neural circuit builds that, almost like you build a muscle. The mechanism is different for connecting those neurons in the brain and reinforcing that track, but the analogy works. It's like muscle memory for neurons. So we know from the neurobiology that that works, and it works really well. And it builds new connections in the brain, and connections that are built in the brain that are then used again and again and again survive in the brain too. They get stronger and they survive. One of the things that we know is that if you have connections in the brain that you've made and you don't use them, they actually do go away. The brain is creating new connections all the time. We didn't know that actually until the last 20 years or so. The brain is creating all kinds of new synapses all the time and pruning ones that are no longer useful to us. So we need to build the strength in that. And that's how we do it, by repetition. And self-monitoring to build that in a person with ADHD requires more practice and more reminding. And we have always kind of known that, but we didn't have the resources to have somebody stand there with them all day and tap them on the shoulder or teach them cues to bring themselves back. But now with computers, uh, and the ways to connect all of that and have smart chips available, we can convert that to technology and we can have that resource. But fundamentally, it's not different from what we would have liked to have been able to do if we had unlimited human resources to do this 25 years ago. We just couldn't do it.
Well, thank you for sharing that. And as somebody who's on our scientific and medical advisory board, I always appreciate when someone else explains it. You've done a better job than I would have done for sure. Yeah, I think the thing that I'm the most excited about, again, we're not hawking product here, but just the thing I think is neat as well is to be able to, as you mentioned, accrue data that the devices collect and to share that back with the educators, the clinicians, the parents, the children themselves, to say when we're seeing the child fidget more or walk more. We're seeing better improvements here or there or in this class. So yeah, it's certainly a paradigm shift right now.
And being on the Scientific and Medical Advisory Board, I have the opportunity to see research that not everybody gets to see. And one of the things I can tell folks on here is that it's an effective intervention for most kids with ADHD. It doesn't work with 100% of them, but I don't know anything that does. But it's very effective for the majority of the kids, and but it's not a cure. It really helps kids improve, but it's not going to make the ADHD completely go away. What it's going to do is improve their performance in any structured environment. And classrooms is where that happens for most kids. Classrooms are the structured environment of their life and where they tend to have the greatest difficulty. And what it does in the end, academically, aside from keeping them out of trouble with the teacher, at least reducing the number of times they get into conflict with the teacher, it increases their time on task spent learning. And that absolutely impacts academics. So I like that a lot.
Can you talk a little bit, Dr. Reynolds, just it could be applicable to Revive or could be applicable to any of the technologies out there for ADHD, but just in general, leveraging technology, through say a 504 plan or something to try to put something in place before special education maybe comes into play.
Yeah, I always like to try prevention. I think it's better to keep kids out of special education if we can, and reserve special education for the kids who really need that level of resources and need that level of involvement. If we can prevent kids from getting into special education, we've probably done a good thing for them, because we also know that once you get into special education, it's very difficult to get out.
Absolutely.
And it's going to be in your school record. So we need to reserve that for kids who genuinely qualify and who genuinely need that level of intervention in the schools. If we can find ways to make accommodations for kids, if we can give them assistive devices of various kinds, if we can give them any kind of cognitive prosthesis, if you will, that will keep them out of special ed, it's better for them. And I know that there's a lot of issues with how do we do that in the schools. And most of those issues center around money and who's going to pay for this. And every district has their own policies on that. So I'm not going to tell you guys what to do with that, or tell you, gosh, you need to run out and buy this or buy that or do this or give it to these kids. Because you need to understand your own district's policies about that. Because in some districts, if you recommend something, they feel like they're on the hook for it, that they have to pay for it and provide it, even if it's a 504 plan and not in special ed. So if you were to say, well, we've got this kid with ADHD, and let's say the Revive device or some other company's device would really help them in the classroom, and you suggest to the parent that that would be a useful thing to do, they might come back to you and say, yes, it would, and you need to pay for it. So there are just a lot of nuances around that, and it really differs from one school district to another, how they deal with that issue and what they're going to say to you about recommending assistive technologies or cognitive prostheses or whatever we want to call them for kids. So pay attention to that, because there's going to be more and more of this coming. There's going to be more and more technology that's going to be available to assist kids, not only in special ed, but who qualify for 504. And we need to have clear policies about that. And school psychologists really need to know what they can and can't say to parents in that context as well. Because you don't want to necessarily create liability for your school district. And on the other hand, you want to do what's best for these kids. And sometimes we just have to walk the razor's edge on that and figure out how to accomplish both goals.
That's great advice. We've had some. I had a school psychologist who reached out a while back and said that they during the Texas STAR testing, actually, she was a Texas school psych. Somebody at a school had said they weren't going to let a child wear a smartwatch, and she said, for this purpose, if the child was wearing a hearing aid, would we take the technology away from them, or eyeglasses? And that's an approach. But I think it's always good, whether it's technology or anything else. The thing I love about school psychology is we have the opportunity to be a liaison between school systems and parents and to fight for kids. So that's very good advice.
That's right. We always want to advocate for what's best for the children. But we also know that if we're going to be effective as advocates for children, we need to understand the policies and procedures within our district. We need to understand the personnel within our district. We need to know who to talk to about what, because if you just go around making everybody mad all the time, you're going to get ignored.
Yeah.
So we don't want to give up advocacy for what's best for the kids at all. That's our primary reason for being there. But if we're going to be effective advocates, we have to learn how to work within our district, within our schools, with our principals, with our directors of special ed, with all those people. We have to be effective with them.
Absolutely. The old adage rings true. You'll better attract with honey than with vinegar. So I think that sums it up. I have a fun question for you. This is one, I used to get this question all the time, and I feel like the research hasn't stopped since I've been stopped practicing school psychology. Can you talk a little bit about what's the real effect of sugar and diet on kids with ADHD? Because parents always want to know.
Yeah. And the effect of sugar and, for the most part, diet on kids with ADHD is the same as it is with all kids. If you eat too much sugar, you're going to have lability in your behavior and attention because your blood glucose levels get on a roller coaster ride. And that happens to anybody. It may be more pronounced in a kid with ADHD because it just exaggerates their existing symptoms, but it doesn't cause ADHD. Eating too much sugar is not going to give you ADHD. A moderate amount of sugar in the context of a balanced diet is not a problem, particularly when combined with proteins. And so we stay off of that glucose roller coaster. That's really the key, is keeping kids off of that glucose roller coaster. And you'll even see that with adults. You may even see that happen to you. If you are in a hurry, you eat a muffin for breakfast, which is mostly simple carbohydrates, and and your body converts simple carbohydrates pretty quickly into sugar, and then you have a Snickers bar for lunch, simply because you're too busy to do anything else. Come 1:30 or 2 o'clock, you may be jittery and irritable and can't sit still, and that can happen to anybody. It's it's that glucose roller coaster. So we need to avoid that. It's not sugar that's causing ADHD. And then the other dietary fads almost that are out there, and some of them are offered as cures for ADHD, like, for example, the Feingold diet, which I think is a beautiful example. The Feingold diet fundamentally argues that the majority of children, a very large percentage actually of children who display what gets diagnosed as ADHD, are actually having an allergic reaction to naturally occurring salicylates. And if you eliminate all salicylates from their diet, you will cure these symptoms and the ADHD will go away. And Feingold argued that it was 80% or plus effective in curing, if you will, ADHD. Well, the research on that, done by independent researchers and done with double-blind placebo-controlled studies, of children where salicylates were eliminated and where children were also getting challenge cookies that were some of which had no salicylates and some of which were chock full of salicylates, and they looked at changes in behavior over time, has indicated that of those with a diagnosis of ADHD, 3% or less show improvement, significant measurable improvement on a salicylate-free diet. Not 3% of kids. 3% of kids with a diagnosis of ADHD will show significant improvement. Well, that's not a very big number. And it's nowhere near the 80+% that Feingold claimed as a cure. And some of that, actually, of that 3% is attributable to the massive changes in family behavior. Because when you go on the Feingold diet, the whole family goes on the Feingold diet. And it radically changes how the family interacts. And it looks like some of the benefits are actually attributable to the changes in the family interactions. And the parents and the children actually develop closer relationships because they have a lot more face time with each other, if you will.
I have a question. I wanted to know, and then I want to launch. We have about 10 minutes left. We've got a hard stop at 2 today, so I want to jump into some rapid fire questions from the crowd. But I have one question or inquiry, if you could share with the audience. You and I were talking yesterday, and you mentioned some of the fish oil, omega-3. Can you talk a little bit about that? I thought it was really interesting.
Well, there are a lot of supplements out there that people are pimping on the internet to treat ADHD. Some of those are natural substances, if you will, plants that they grind up into powder that actually contain sedatives. They have a sedative effect. I don't recommend that you use that with kids. We don't need to sedate these kids. You can sure make ADHD symptoms go away if you give kids enough Xanax. And just because it's a naturally occurring substance that didn't come from a pharmaceutical company doesn't mean you're not sedating kids. So I don't recommend any of those kinds of supplements like Calm and those things. That's just, I think, a bad idea. There is one thing that's recommended out there, though, that actually has good research to back it, and that is a high dose of omega-3 fatty acids. It does very much look like omega-3 fatty acids, especially as derived from fish oil, have a measurable benefit in many children with ADHD. And that's because we think the omega-3 fatty acids are broken down into other compounds within the body. And one of the compounds they're broken down into is animidine. I have trouble saying that with all the N's and syllables in there. But anyway, it breaks down into a neurotransmitter in the brain and creates more of a particular neurotransmitter in the brain that is probably best characterized as a neuromodulator, which has a little bit of a soothing effect on the brain. And it's actually related to certain cannabinoid substances. And this particular neurotransmitter binds to the same site as cannabinoids in the brain. So it exerts a measurable soothing effect on the brain. Now, it is not going to cure these kids. It's not going to make their ADHD go away. They're still going to be impulsive. They're still going to be distractible. But it does lessen the symptom display to enough that we can detect it.
That's fantastic.
And you know, if it helps, right? And the other thing about it is that it is very much side effect free. It just doesn't seem to harm kids at all. But it takes a prescription level dose. Now you can still buy it over the counter. If you look at the typical fish oil capsule that you would buy, it would take 6 of those to get to a pharmaceutical grade dose. It takes 6 of those a day. And there is a prescription fish oil out there that is 6 times what a single dose of fish oil capsule is, which you'll also see in places like Walmart and some of the big box club stores and that kind of stuff. They'll have double strength and triple strength fish oil. 2 of the triple strength fish oils is equivalent to the prescription fish oil. And it does have at least some measurable benefit. We do not recommend using omega-3s derived from flaxseed, particularly with boys, because the flaxseed derivative of the omega fatty acids promotes androgen also, and the fish oil derivative does not. So particularly with boys, we prefer fish oil and not flaxseed oil.
So interesting. See, you learn something new every day, especially when you're hanging out with Cecil Reynolds. So thank you for sharing that. Let's switch over to some rapid fire questions, Dr. Reynolds. We have about 5 minutes and several questions. So I am not a master of economy of speech. You're far better than I am. So I'll challenge you. Maybe we could try to spend 30 seconds to a minute per question and just try to knock some of these out. I will transition from the fish oil and just say, from the revive side, we always suggest you consult, your physician, pediatrician, but this is so helpful to hear. I was fascinated when I heard that yesterday. So I wanted to share that with everybody. All right, let's rapid fire some questions. We have Cindy Ross has a question. Let's see. Oh, I'm sorry, it's Joyce. Joyce Dvorak wants to know, other than medication, Dr. Reynolds, how could one potentially test the impact of attention anxiety? For example, is there an SSRI for anxiety, but focus remains a concern? Does that suggest it's more likely ADHD?
Well, SSRIs are a secondary medication for ADHD. So diagnosis by drug response is generally a bad idea. It's one that's still popular with pediatricians, although we know that diagnosis by medication response is quite inaccurate, because even kids who don't have ADHD show behavioral reductions and more focused attention when they take Ritalin, for example. And SSRIs have a similar effect as stimulants. What they are doing is creating an increase in either serotonin or dopamine in the brain. And SSRI is a selective serotonin reuptake inhibitor. And so it's increasing serotonin levels in the brain primarily, and secondarily, they impact dopamine a little bit too. Amphetamines or stimulants have a much bigger impact on dopamine production, but secondarily increase serotonin. And in some kids, the SSRIs work better than stimulants, but the right diagnosis is still ADHD. So don't attempt to make a diagnosis by drug response, because you can get behavioral changes whether a kid has that diagnosis or not. So it's just not a good idea to diagnose by medication response.
You heard it from Dr. Reynolds. I've got a Basque specific question, and I thought it was so cool 15 years ago when I got to ask you about the Rios question when I called you. So let's give you a Basque question. Lisa French says she uses the Basque a lot in her evals, and she finds it very useful when ADHD is suspected. I like to use 2 norm groups, general combined and ADHD gender specific, because I feel it gives me an idea of how severe the symptomology is. Do you think this is a valid practice?
Well, you want to make the diagnosis based on the combined gender norms, but using the ADHD gender specific norms will give you an idea of the severity of the symptoms relative to other children the same age who have a diagnosis of ADHD and are of the same gender. And I find that most useful actually in teasing out comorbidities. For example, if I see, well, this kid certainly looks ADHD, but when I look at the ADHD gender specific norms, wow, their depression scale is, a standard deviation above that of other children who are also boys who also have ADHD. That tells me that in my process of triage, if you will, I don't need to just treat ADHD in this kid. I need to be really sure that whatever we do, we pay attention to the symptoms of depression as well. So I use those norms as part of my triage process and looking at what interventions I think are needed to happen now and what interventions I might put into place later as we get the ADHD or other symptoms under control. So I use two sets of norms, but I use the combined gender norms for initial diagnosis because all of the research that we've done say they are the most accurate for arriving at a diagnosis. The other norm groups can be helpful with triage and deciding what to treat first.
I've got another question for Dr. Reynolds. Can you suggest school-based tools to help make an appropriate differential diagnosis other than a cognitive assessment, brief social emotional memory test?
Mm-hmm. Well, obviously, my perspective is that because of all the comorbidities, you've got to have a broadband rating scale like the BASS. The BASS 3, I think is the best. Some people might think I have some bias in that, but I remind them it's not BIAS, it's BASC. But you've got to do that. And then you can do follow-up assessment in areas with narrow band scales, things like the Revised Children's Manifest Anxiety Scale, for example. There are other things like that you can do that are school-based assessments. But you've got to have a broadband rating scale if you want to get the diagnosis right and be sure that you cover the comorbidities. There are other kinds of things you can do to look at attentional issues. For example, trail making tests are a great way to look at that. They're fast, they're inexpensive. The comprehensive trail making test takes 8 minutes. The whole test kit's about $120. And it's 8 minutes a kid, and it gives you a great look at attention, but it also gives you a great look at frontal lobe function. In addition to that, under multiple conditions, all in about 8 minutes. So there are a lot of things like that, and you just have to put that together. And I don't have a standard battery that I use for every kid that comes in who's suspected of ADHD. I have a complete flexibility. I don't decide what measures I'm going to be using until after I've been through the structured developmental history, interviewed the parents, and done a clinical interview with the child. And then I make my decisions about what assessment devices I'm going to be using. And often in the middle of my evaluation, it changes because of something I found as I was doing the assessment. Well, someone asked what that 8-minute assessment was, the comprehensive trail making test, the CTMT, which is another one of mine. I can't help but recommend mine because if I didn't think they were good, I wouldn't have developed them. So.
Well, you answered a question I was going to ask you from Anna. We have time for one more question. This is a question from Tom, and this is a question I think a lot of school psychs would be interested in, which is why I've picked Tom's question for our last one. Tom Gambino wants to know, what are Dr. Reynolds' thoughts on testing students currently taking medication? Would best practices be testing the student while taking their medication, or had them discontinue or cease use to see how they would do without? I know this is also an ethical question, especially in schools.
Yeah. Well, I'm actually glad you asked that question because it's a question nobody likes my answer to. And I have a number of answers like that. But the answer is to ask yourself first, what is it I want to know about this child? And remember that tests only answer questions. And sometimes people say, well, gosh, what test should I give to a 9-year-old? And I'm like, well, what questions are you trying to answer about that 9-year-old? Because tests just answer questions. Know the questions that you want answers to before you decide when to test and what test to use. So my answer is, and this is why it's so unpopular, I'm not going to tell you which one is right, because sometimes when I see kids, I want to know how they perform and what they're like on these tests when they're not on medication. Sometimes I want to know how they are doing when they are on their medication. So it depends on which question I want to answer. If it's a kid who already has a diagnosis and we're doing follow-up to see if their cognitive performance is really improving, then I'm going to test them while they're on medication. If for some reason, whoever is providing the intervention, writing the prescriptions or whatever, says, well, I'm not sure Johnny needs to continue on medication, then chances are the question I want to answer is, well, let's see how he does without it. So let's discontinue the medication and reevaluate and see if their performance has improved over their initial performance when they first got the diagnosis and were never on medication. There's no ethical issue there, because the question is, should this child be continued on medication or not? And one of the ways to answer that is to see how they behave when they're not on their medication and how they behave when they are on their medication. So it just depends on the question you want to answer.
I love that response, Dr. Reynolds. I'm not sure who would hate that other than people who just want a quick, fixed, quick and dirty answer. I think that's the perfect response. So with that, we've run a little bit over time, but we wanted to answer as many of your questions as we could. So I want to give Dr. Reynolds a huge thank you for coming out today and speaking with me and all of you. So Dr. Reynolds, thank you very much.
Yeah, and thanks everybody for being here. I appreciate that. Even some of my former students, I know from some of the names, showed up on there for some ongoing torture of listening to me. So thanks for showing up, guys.
Thanks, everybody.